Hello guys, today we're going over neurological emergencies, head trauma, and stroke. Here we have the objectives. We're going to go over the anatomy and physiology of the nervous system. We're going to discuss stroke, pathophysiology, exam, and transport criteria. We're also going to go over head trauma and assessment associated with increased intracranial pressure. We're also going to talk about some of the pathophysiology of common neurological disorders, the neurological exam, and ALS interventions. Alright, so let's begin with anatomy and physiology and relevant pathophysiology. Here you'll notice we have the bones of the skull. On the right hand side, what we're looking at is an interior view of the basilar skull. So this is the base of where the brain sits on. What I really want you guys to pay attention to here is if we look at the top of this picture on the right, we have the ethmoid bone. Now if we look over to the picture on the left, if we look in the area of where the nose is, that is the ethmoid bone. So for basilar skull fractures, we do not want to give like an NPA or insert anything into nose because it can protrude into the cranial cavity. This is the bone that's directly connected from the nose to the basilar skull area. Now also notice we have the zygomatic bones in the maxilla here. These are very strong bones. So when we move on to specific head injuries, facial trauma, specifically fractures, we have our Lefort fractures. So Lefort type 1 is going to be a maxillary fracture, and you can see that on the right where that line of demarcation is. After Lefort type 1, we have a Lefort type 2, and this is going to be a floating maxilla, so you can see the line of demarcation is going along the entire maxillary bone. So if we look at the left hand side, that entire purple bone is that line of demarcation, where previously it's going horizontally through the middle of the maxillary bone. And then finally we have a Lefort type 3, and this is a significant fracture because it takes a lot of force to fracture the zygomatic bone. So we have a fracture. The line of demarcation is going to be beginning in the zygomatic bone. That's where you can feel your cheekbones, the prominence of your cheekbones, and it's going to go horizontally across and fracture the whole face. This is considered like a floating face type of fracture. So these Lefort fractures are severe injuries, not because the actual fracture is life-threatening, but because of the amount of force that's required to cause these fractures, especially at the Lefort type 3. So that force that cranium is experiencing is being transmitted throughout. So that's going to cause some brain injuries, and it can also cause some basilar skull fractures. So what do we mean by a basilar skull fracture? If you recall, we're looking at the basilar skull region here on the picture on the left, and a basilar skull fracture is going to be a fracture to any of those bones. So on the picture on the right, we have different examples of a basilar skull fracture here. So what we have here are signs of a basilar skull fracture. On the right hand side we have raccoon eyes. This is bruising around the eyes. And in the lower part of that we have battle signs, which is bruising behind the backs of the ears. They say that these are typically late signs, but in a severe head trauma we might see these on scene. Another sign is going to be leakage of cerebrospinal fluid, and we can have cerebrospinal fluid leak either from the ears or from the nose. If you recall earlier, we had the picture of that ethmoid bone for the basilar skull fracture. If we have a break in that bone, it can leak into the nose as well. So typically for cerebrospinal fluid, we'll see like a halo forming around a blood drop if that were to fall on the sheet, or if we were to swipe that up with a gauze pad to see if it's cerebrospinal fluid. So, as stated earlier, these fractures by themselves are not necessarily life-threatening injuries, but it's the force of these fractures that is going to diffuse to the brain that causes the injuries that we're really worried about. So we're going to cover the different parts of the brain. The first part is going to be the cerebrum, and we have different lobes of the brain that perform different functions. The frontal lobe is going to be primarily responsible for cognitive function, voluntary movement, behavior, and language. The parietal lobe is going to be language, touch, temperature, taste, and movement. The temporal lobe is going to be memory, language, and hearing. And then the occipital lobe is going to be primarily visual. So any disturbances to any one of these areas of the brain is going to cause focal neurological deficits in whatever function that these lobes carry out. So where the lobes specify different regions of the cerebrum, we also have two different components of the cerebrum. We have the cerebral cortex, which is composed of the gray matter, and this is primarily responsible for the higher level functioning of our brain, and it's composed of neural cell bodies that fold in on themselves to create many folds. So this increases the surface area of our cerebral cortex, all these folds. So typically a ischemic stroke, we're going to have an issue within the cerebral cortex, so there might be a blockage or ischemia to a certain part of the brain that's going to cause a focused neural deficit, which is hopefully something that we can pick up on our stroke exam. Now moving down to the white matter, this is going to be the deeper components of the cerebrum, and it's primarily composed of myelinated axons, and these are responsible for connecting different areas of the cerebrum together. So for example, if we were to have a brain bleed, a hemorrhagic stroke that's causing pressure and swelling, and it's compressing the white matter of the brain is not going to be able to communicate with different areas of itself. So which is why for hemorrhagic strokes we typically have patients that are just unresponsive, unrousable, whereas with our ischemic strokes we typically have more focused neurodeficits. Moving deeper into the brain, we have the basal ganglia, and this refers to a group of structures primarily responsible for motor control, motor learning, and other functions such as behavior and emotion. So Parkinson's disease is a progressive degenerative disorder that affects the nerves within the cells of the basal ganglia. So the cerebral cortex, our brain decides what our body, the movement that our body wants to do, and the basal ganglia is responsible for the execution of that smooth movement, which is why in Parkinson's disease you have very shaky movements. So the basal ganglia creates dopamine, which is the neurotransmitter which helps propagate body movement. Going deeper into the brain, we now have the cerebellum, and this sits just below the occipital lobe and behind the temporal lobes of the brain. And this coordinates voluntary movement as well, and also controls things such as posture, balance, coordination, and speech. So when we have a head injury patient with increased intracranial pressure in their posturing, what we're seeing is compression of the cerebellum due to increased ICP in the brain. So here we have pictures of posturing as a sign of severe head injuries associated with increased ICP. And this decorticate posturing that we see on top is going to be flexion of the arms and stiffening of the feet down at the bottom. And we have decerebrate posturing, which is going to be extension of the arms. So those are flexion and extension to pain on our Glasgow Coma score. The last component of the brain that we're going to talk about is the brainstem. The brainstem is comprised of the midbrain, the pons, and the medulla oblongata. The easiest way to think about the midbrain is as a middleman. All neurons lead through the midbrain, so all communication between the brainstem, the rest of the body, the brain, goes through the midbrain. Below that we have the pons, and the pons have many functions, but its primary one is going to be respiratory control. And then moving down from there we have the medulla oblongata, which also regulates breathing but circulation as well. So if we think about Cushing's triad, we have increased blood pressure, decreased heart rate, and decreased respirations. So moving to the medulla oblongata, it's responsible for breathing and circulation, and with circulation it primarily affects pressure and heart rate. So it ensures an adequate circulating volume is present throughout the body through stretch receptors throughout the arteries. So when we have an increased intracranial pressure, It's the medulla oblongata that's responsible for that widening pulse pressure that we see by increasing the blood pressure, but also by regulating the heart rate and uh, causing the heart rate to slow down. So the medulla oblongata is responsible for Cushing's triad, and Cushing's triad is typically seen when we have herniation on the brainstem. Now moving to the pons, another part of Cushing's triad is going to be the Cheyne-Stokes respirations. So we talked about the pons, its primary function is respiratory control. So there's different areas of the pons. There's the apneustic center, which increases stimulation to the phrenic nerve, which is going to increase respiration, inspiration. And we have the pneumotaxic center, which is going to decrease stimulation to the phrenic nerve, which is going to cause us to stop breathing. So when we think about Cheyne-Stokes respirations, we have very rapid, deep breathing followed by periods of apnea and very shallow respirations. This is because of the herniation of the brainstem and it affecting the pons. Moving on from the brain, we're going to talk about the meninges. The meninges is going to be 3 layers that surround the brain as well as the spinal cord. So we have the dura mater, we have the arachnoid mater, and then we have the pia mater. Now we have the epidural space, the subdural space, and the subarachnoid space. Now notice there's not really a epidural space, but we do form an epidural space in some of our head traumas. So what we have here are going to be different types of bleeds and how it relates to the meninges. So on the left we have an epidural hematoma, an epidural bleed, and this is going to cause a separation of the dura mater from the cranium, which is normally affixed. So a classic sign of an epidural bleed is going to be a loss of consciousness upon point of injury, because these are going to be high impact injuries, and then this artery is going to start bleeding and our patient's going to regain consciousness, but because of the fast arterial bleed, there's going to be a quick buildup of intracranial pressure and swelling, and then our patient is going to go unresponsive again. So epidural bleeds are typically, loss of consciousness, regain of consciousness, and then total loss of consciousness. Now moving on to the right, we have a subdural bleed, and this is going to be caused by a rupture of a vein beneath the dura mater. Now these could be fast or they can be delayed in onset. Our patient could have a loss of consciousness or they may not have a loss of consciousness. The most important thing for any head injury we want to assess is our patient on blood thinners. The reason being, they could have a slow bleed that's not going to clot in the subdural space, that's ultimately going to respond to increased intracranial pressure and a loss of consciousness and possibly death. Especially for our elderly patients, they typically have shrinkage of the brain as part of the normal aging process, so they can go a long while due to that extra space in the brain before a subdural bleed is noted. So elderly patients, patients on blood thinners, or chronic alcoholics, because they also have shrinkage of the brain. All those patients, for any head injury, we want to ensure that we try and get them to the hospital for CT if we feel that's warranted. If they refuse to go, ideally, maybe they could have someone that keeps an eye on them for the next couple of days, because the onset can be hours to days. The last type of bleed that we may have with the meninges is going to be a subarachnoid hemorrhage. This is considered a type of hemorrhagic stroke, and the most common cause of this subarachnoid hemorrhage is going to be trauma, but it can also be caused by a brain aneurysm. And symptoms for a subarachnoid hemorrhage include a sudden onset of severe headache, possibly stiff neck, photophobia, and other stroke-like symptoms. So this is going to be the type of stroke where the patient suddenly has the worst sudden headache of their life. So there are many types of head injuries, but a traumatic brain injury is specifically an injury that results in damage to the brain. So TBI technically would be something from a minor concussion all the way up to severe brain damage. So we have superficial injuries to the head, which is going to be any injuries to the outside of the head. These can be lacerations, bruising, or fractures. We talked about basilar skull fractures and facial fractures with the Lefort fractures, but they can also be linear fractures of any of the cranial bones or depressed skull fractures as resultant from blunt force trauma. And remember, these types of forces are going to transmit themselves to the brain and cause additional brain injury as well. And then we have internal injuries to the brain due to that blunt force trauma. So outside of the brain itself, we have bleeds like in the epidural or the subdural space or the subarachnoid bleeds. And then we also have injuries within the brain itself to include brain contusions, intracerebral hemorrhage, and diffuse axonal injuries. We're going to discuss axons later, but this is essentially a shearing of the axons and they can no longer communicate and transmit impulses. So this typically results in a coma type patient. Assessment of our head trauma patients includes C-spine precautions. We have to remember that a lot of these head injuries require a significant amount of force, so that's going to be associated with a high incidence of cervical injuries. So C-spine precautions are usually always recommended for these types of head injuries. We also have to be cognizant of the airway, especially if we're maintaining C-spine precautions. We're going to have to use a jaw thrust maneuver. Also remember, if they have a Glasgow score of less than 8, that's indicative of a severe head injury, and they probably do not have the ability to maintain their airway. So we need to intervene with advanced airway support. Breathing is also going to be a factor. There's significant mortality associated with hypoxia in brain injuries, so we need to ensure that they have adequate respirations, and if they don't, that we are ventilating for them and delivering them the oxygen that they need. And finally, circulation. There's also significant mortality associated with hypotension in traumatic brain injuries, and hypotension leads to hypoxia, decreased perfusion of the brain. So we need to maintain their blood pressure, ideally a systolic blood pressure of approximately 110 to 120. Another thing with our assessment is going to be pupils. We want our pupils to be pearl, equal and reactive to light. If we have unilateral dilation and constriction of pupils, that's indicative of nerve contusion and compression associated with increased intracranial pressure of the brain. Also, if we have just constricted pupils on both sides, that's compression of the midbrain or other lesions, so that's also a severe sign that we may see. And then if they have just blown pupils on both sides, it's going to be a bilateral compression of that ocular nerve, which is also indicative of a head injury. Now, we can't really talk about head injuries without talking about the Glasgow Coma Score, and this is useful in predicting the severity of our head injury. So a GCS of 13 to 15 is considered mild, whereas a GCS of 9 to 12 is going to be a moderate brain injury. Anything less than 8 is considered a severe injury. So on the right here we have the different components of the GCS, and I'm not going to review this, but it's in the protocol and it's on the back of all of our green sheets. So even if you do not commit this to memory, you have that resource for every call that we go on. So during our head trauma assessment, some red flags, if we see any of these, is going to be suggestive of a significant head injury. If they have an amnesia, they can't remember the event, seizures, they have a severe headache, nausea, or vomiting, they have altered mental status, those dilated or fixed pupils that we talked about, signs or symptoms of a basilar skull fracture, or if they have focal neurological deficits or impaired vision, and finally agitation or combativeness. All of these are red flags in our trauma assessment for a head injury. Treatment of our head injury patients is going to include spinal precautions, so we want to make sure that we package our patients appropriately, place them on a backboard if indicated, and a C-collar. If they have any loss of altered mental status, loss of consciousness, we cannot rule out spinal injury, so typically we're always going to put these patients on backboards and collars. We're going to place an advanced airway if the GCS is less than 8 or ventilations are not adequate and we are unable to ventilate effectively. So even if the patient has a GCS of 10 or 11, They may have the ability to maintain their airway. If we can't ventilate them effectively due to obesity or whatever reason, we may need to consider an advanced airway, because hypoxia is a severe event in a head injury patient that it causes increase in mortality. We want to maintain their respirations at 10 breaths per minute and their end tidal at 35 to 40 if they're not showing any signs of herniation. So remember, those signs of herniation that we talked about are going to be the Cushing's triad, as well as the posturing, the flexion or the extension. If they are showing signs of herniation, we want to maintain their end tidal CO2 between 30 and 35, and this is typically achieved with a breath rate of 17 to 20 breaths per minute. What this does, this bringing our end tidal CO2 to 30 and 35, causes slight vasoconstriction, which hopefully is going to reduce some of that swelling and reduce some of that herniation of the brainstem that we're seeing. We want to prevent our patients from vomiting, because this is going to cause a sudden acute rise in intracranial pressure, so we're going to give them Zofran per protocol. And we also want to manage any seizures that they may have or any agitation that they may have with some Versed. And finally, we're going to maintain their systolic blood pressure at 110 to 120 systolic, or a mean arterial pressure of 85 to 90. And we're going to do this with 200 milliliter boluses up to 1 liter of saline. So I wanted to talk a little bit about increased intracranial pressure and maintaining cerebral perfusion, and why a decrease in blood pressure increases the mortality of our head trauma patients significantly. So I took this slide, I added the orange arrows, and I added the blue dashed line. So typically, for a normal patient with normal intracranial pressure, they probably need a systolic blood pressure of approximately 65 to maintain that threshold of cerebral perfusion pressure indicated by the dashed gray line. Now I arbitrarily placed this dashed blue line above it, and that represents the threshold for a patient with increased intercerebral pressure that they need to maintain that perfusion. So if we look at the second arrow on the right, it looks like their blood pressure needs to be above 120 systolic in order to maintain the minimum threshold to perfuse their brain. So again, these numbers are slightly arbitrary in this slide, but it highlights the importance of maintaining that systolic blood pressure, because in any incidents with increased intracranial pressure, we're going to have a reduction in blood flow, and we need to compensate by maintaining that higher systolic pressure. So moving on to some more of the nervous system. The nervous system is composed of the peripheral nervous system and the central nervous system, which includes the brain and the spinal cord. So the breakdown of the peripheral nervous system, we have the autonomic nervous system and we have the somatic nervous system. Now the somatic nervous system is primarily going to control skeletal muscle movement, so motor output, but it also is responsible for sensory input. And the autonomic nervous system is going to be broken down into our sympathetic and our parasympathetic divisions. So our sympathetic is going to be our flight response, where our parasympathetic is going to be our flight response, so the calming response. So now that we discussed the components of the nervous system, we're going to talk about the cells of the nervous system. And the primary one is going to be the neuron, and the neuron is responsible for receiving and sending electrical impulses, communications from the brain to the body and vice versa from the body to the brain. So the main component of the neuron is going to be the cell body, or the soma, and this receives the impulses from the dendrites, and it sends the impulse down its axon to the axon terminals, where it crosses the somatic gap and communicates with the next neuron, the soma, down the line. So when we talked about the diffuse axonal injuries earlier in our head traumas, this is going to be a shearing of these axons that we see here due to a rapid acceleration or deceleration of the brain inside the head in a counter-coup type of injury, and these patients can typically end up in a coma for a prolonged period of time. The next cell type of our nervous system is going to be the oligodendrocytes. And the oligodendrocytes form the myelin sheath insulating the axons of our neurons. Now, this myelin sheath increases the rate of transmission of electrical impulses throughout the nervous system, which is responsible for that instantaneous communication from the body to our brain and vice versa. Now, these cells are called Schwann cells in the peripheral nervous system. So one of the things that we can see that affects the myelin sheath in these oligodendrocytes and Schwann cells is Guillain-Barré syndrome. This is thought to be an autoimmune response occurring after a viral infection, and what happens is this disorder attacks the peripheral nervous system, damaging the myelin sheath. So this typically presents with ascending weakness and paralysis, ultimately affecting respirations where the patient's going to require mechanical ventilations. So it may start with weakness or tingling in the hands and feet, and it works its way up to the point where they can no longer breathe. It can also affect the autonomic nervous system and cause severe fluctuations in their blood pressure and irregularities in their heartbeat to the point where they need a pacemaker. And if we're seeing these types of signs and symptoms, we need to treat the symptoms that are presenting. So if they're hypotensive, we need to treat that. If they're bradycardic, we need to treat that, etc. Another thing that affects the myelin sheath is multiple sclerosis. And what happens is the body attacks these oligodendrocytes and Schwann cells, causing demyelination throughout the body. Now, this happens everywhere, and it's progressive. So the symptoms are wide-ranging, and they can often have multiple periods of remission where all of a sudden they're at 100%, and then it typically progresses each time it reoccurs. So the complications of this are what's fatal. It's not necessarily the disease itself, and treatment's getting better with multiple sclerosis. Currently, the average life expectancy is 5 to 10 years less than normal. So it's not completely debilitating, but it does hinder the quality of life that these patients may have. The next cell type we have are the astrocytes, and the astrocytes keep a tab on multiple neurons at once. They're constantly monitoring the functions of the neurons and the extracellular environment, so they're responsible for maintaining that homeostasis within the brain. And they do this by maintaining the blood barrier. They remove waste within the brain, and they break down plaques, and they maintain the electrolytes and everything responsible for this neuronal transmission. So if we have anything that affects the function of the astrocytes, it can lead to certain conditions. For example, if it's not removing the plaques within the brain, this is a contributing factor to Alzheimer's disease, which is caused partially by a buildup of plaque within the brain. It's also impaired functioning of the astrocytes is also a possible contributor to Huntington's disease and epilepsy. So especially if we consider like the electrolytes surrounding the axons, the neurons of the brain. If we have abnormal electrolytes, we might have abnormal brain activity, which is going to lead to possibly seizures. So the astrocytes are a possible contributor to epilepsy as well. And then finally, the last thing we're going to talk about are the microglia, and these are the white blood cells of the nervous system. They're macrophages, and they remove damaged neurons and infections within the brain. So encephalitis, meningitis, these things, the microglia are going to be responsible for helping us fight. They can also attack healthy cells and autoimmune disorders, contributing to any of the pathologies that we discussed. Okay, so the last thing we're going to talk about is stroke pathophysiology and exam. We went over stroke extensively in the stroke protocol review, so this is not going to be as detailed as that review was. So if you have or need further clarification on stroke, I invite you to go back and watch the stroke protocol review. So we have two different types of strokes. We have ischemic strokes and we have hemorrhagic strokes. Ischemic strokes can be treated at primary stroke centers, which are the 3 hospitals that we can transport to. and they require the use of TPA or other similar medications to help break down the clot within the artery of the brain. Hemorrhagic strokes often cause an increase in intracranial pressure, and if severe, these patients need to be treated at a comprehensive stroke center. In either case, it's of utmost importance that they get to a CT as soon as possible so they can begin the appropriate therapies. So moving down to our ischemic strokes, we have two different types. We have a thrombotic stroke, and this is typically going to be a blood clot or thrombus that blocks flow of blood in the brain. So if we look at the picture here on the left, we have a thrombus that's building up on the side of the artery, and it's decreasing the flow of the brain. Now if we move to the embolic stroke, we have a fatty plaque or blood clot that forms somewhere else in the body. So typically for like our AFib patients, a clot might form in the atria and it might get thrown to the brain and cause an obstruction, and this would be considered an embolic stroke. Either way, treatment's the same with like TPA or other similar medications. Now here what we're seeing is a hemorrhagic stroke, and we have a buildup of blood at any region of the brain. Now if it's small, we might see focal deficits depending on where it is in the brain, but as it grows and increases, we can see here that we start to have herniation where we have this left hemisphere pushing in towards the right hemisphere, and we can see the compression of these ventricles within the brain. So that's why typically our hemorrhagic stroke patients are going to just be totally unresponsive, unarousable, and they'll probably have abnormal pupils. Whereas if we go here and we look at our ischemic type of strokes, it typically affects a specific area of the brain, which is why we have those very specific focal neurological deficits that we're going to assess for in our stroke exam. So moving on to the stroke exam, we had the BFAST, which is currently what we're using, and this is much more comprehensive than the Cincinnati stroke scale. So remember, we discussed all the different functions of the brain, the different lobes and what they do. The Cincinnati stroke scale just assessed for facial droop, slurred speech, and arm drift. But there's so much more. There's so many different areas of the brain that cover other things that if they're having a stroke there, that the Cincinnati may be inconclusive. So the BFAST exam is much more specific than the Cincinnati stroke fast. And depending on how we perform it, it can be more comprehensive than just simply balance eyes, face, arms, speech, and time. So let's get into it. First we have balance. And balance refers to trouble walking, dizziness, or loss of coordination. So dizziness is an altered sense of spatial orientation or a distortion of where we are within a space, and our balance just may feel off. So that's distinguished from vertigo, where vertigo is a sensation of self-movement within a fixed environment or the movement of our surroundings. So typically like the room feels like it's spinning around us. This would be considered vertigo, whereas dizziness might just be like we just have a spatial disorientation of where we're at. Vertigo is typically more debilitating than dizziness. Another thing is going to be loss of coordination, and this can be gross or fine motor coordination. So one of the things that we can assess here, and it makes this assessment a little bit more comprehensive, is we can ask them to touch their pinky finger to their nose. And it's important that we ask them to do this without demonstrating it, because this is going to assess their ability to not only comprehend what we're saying, but to also demonstrate the fine motor coordination to do that task. So if they can't comprehend what we're saying, but we show them what to do, they may possibly do it. But if we just say it and have them process that information and then carry out the task, that's going to be a slightly more comprehensive and more informative test for balance and loss of coordination. The next component of the BFAST is going to be the eyes. So we're assessing for trouble seeing, blurred vision, or loss of vision, and we're looking for acute vision changes, which could indicate changes within the vision centers of the brain. So remember the occipital lobe. So this can be an ischemic stroke in the occipital lobe, or it can be a hemorrhagic stroke within or impinging upon the occipital lobe or the optic nerves within the brain. So what we want to do is ask if they have any trouble seeing, any acute changes to their vision, if they have blurred vision, if that's abnormal for them, or if they have total loss of vision, whether it be in their peripheries or just direct loss of vision. So another thing we can do is a vision check. So the first thing we can do is have them track our finger and just have them look straight ahead and follow your finger. We're going to be looking at their eyes and make sure that their eyes are tracking. It's possible that they might be tracking just fine, and all of a sudden one eye stops and it cannot track that finger any further. Sign that or symptom they may have for this would be like double vision. That would be indicative of compression and possibly of their ocular nerve, which can be a sign of a stroke. Another thing we want to test for is their peripheral vision. So we take our fingers and we bring them in and we ask them when they can see our fingers. If they can't see one of the fingers, then they have decreased peripheral vision on that side, and that also is a concerning sign. And then finally, we want to check for visual neglect. If we're to be like, okay, can you see here? How many fingers am I holding up? They might say 2. They might be just as good over here. Hey, I only see 1 finger over here. But what we want to do is we want to ask them, how many fingers am I holding up? They might only see this side here. They might only see 2 because they're neglecting this side. Whereas if by itself they can see it, but when they're asked to focus on both fields, they may neglect the other side. So that is another sign of a potential stroke. So next we are going to be assessing the face, and we're looking for facial droop, numbness, and just general unequalness on both sides. So we're going to have our patient smile for us and have them show us their teeth. And if they can show us their teeth equally on both sides, that's usually an indication that they don't have facial droop. We want to be wary of previous strokes or patients with Bell's palsy that might have this previous existing condition of Bell's palsy or a stroke where it causes facial droop. A Bell's palsy facial droop, they're going to have the inability to really close their eyelid, and they may have irritation to the eye, so a red eye. So that would be something that's been going on chronically, and it's not a sign of an acute facial droop as a result of a stroke. They're also going to have the inability to wrinkle their foreheads for these Bell's palsy patients. So this is what a facial droop patient will look like on the left. This is pretty pronounced, but it can also be less pronounced and a little bit harder to tell. So it's important that we have them show us their teeth to really assess the quality of that. So the next thing we're going to test for is arms. We're looking for paralysis, numbness, unequal strength, and weakness. And we're going to demonstrate a arms test. So for an arm test, we can attest for strength in their arms by assessing for arm drift. So we're going to have them place their arms out in front of them and close their eyes. So an arm drift is going to be if their eyes are closed and the arm just starts to go down. It's important that we have them close their eyes because if their eyes are open, they can see their arm going down but begin to compensate for it. So that would be a good test for weakness in one side. Another thing we can do is we can be like, okay, push up on my arm. Can you push down on both sides? And we can also do that type of assessment on their legs as well. Another thing we want to assess for is touch. So while they're doing their arm drift with their eyes closed, what we can do is while they're holding their arms out, we can touch both hands, and we can be like, okay, which side did you feel me touch? And if they say, I felt you touch the right, or I only felt you touch the left, as opposed to both of them at the same time, that can be another sign of neglect. So do both at the same time, and if they say they feel both and they don't have any drift, then they probably got good strength and there's no neglect, and they might not be having any issues with that component of the exam. Moving on to speech, we have slurred speech, loss of the ability to speak, or unable to find the right words. So speech abnormalities can be representative of different areas of the brain. For example, they may have appropriate speech, but they're just having a hard time saying those words. They're slurring those words. So that's primarily going to be affecting the ocular motor portion of their brain, but it's not affecting their ability to comprehend what we're saying or for them to formulate the correct words. However, our patients may have an inappropriate response. They might have decreased comprehension of what we're saying. So remember when I said we can ask them to touch their pinky finger to their nose. If they're having a hard time understanding what they're saying, what we're saying, then that can be a sign that something is going on. Now again, the patient may be able to comprehend what we're saying just fine, but they cannot formulate a correct response. And we're going to see these patients that are just agitated because they understand what we're asking them, but they just can't get it out correctly. So we can think of alternative ways to communicate with our patients by having them maybe squeeze our hand once for a yes or twice for a no, and ensure them that we understand that they're having difficulty formulating the right types of words. And then finally, we have time. So we want to document the last time they were seen normal and the time that symptoms were noted. And it's very important to distinguish between these two, because in some cases they're the same, but some cases they're not. So if you're with your significant other and all of a sudden you notice a sudden onset of these stroke-like symptoms, their last seen normal time and their symptom onset time is going to be the same. However, if you come home and your significant other is presenting with these symptoms and you've been gone for 6 hours, you do not know necessarily when those symptoms started. You only know when the last time you saw them was. So it's very important when we're talking to our patients that we try and nail down these two very distinct specific types of times, because that's going to alter the treatment that they receive at the hospital. A lot of the therapies that they're going to receive are time sensitive. Now, transport criteria. All the hospitals that we transport to in McHenry County are primary stroke centers. So we want to take the patient to the closest primary stroke center so they can receive the treatment as quick as possible. In most cases, that's going to be Woodstock Hospital. However, in some areas of our district, it might be closer to go to McHenry, or, for example. So Woodstock is a great hospital to take our stroke patients, and if our patients' families don't want them transported there, it's just very important that we communicate with them why it's important that we go to the closest CT, and that's ultimately going to have the best positive effect for our patient. Alright, that concludes our lesson here. I took some feedback from you guys on some of the last ones. I tried to make this a little bit more expedient, so hopefully it wasn't too long. But I did want to include some information in here that we normally don't talk about. Alright, you guys have a great day. Bye.